Hello, I'm Susan Cole.
And I'm Matthew Hodson.
And welcome to aidsmapCHAT, our live broadcast bringing you news about HIV for people all around the globe.
Yeah, we've got another absolutely brilliant lineup of guests this week. We've got Tristan Barber. He's an HIV doctor who is also living openly with HIV from the Royal Free Hospital in London. We have Gina Brown. She's a member of the Southern AIDS Coalition. And we have a wonderful HIV activist from Turkey, Arda Karapinar.
What an absolutely brilliant lineup we have this week. I'm very excited. So, Matthew, what have you been up to since we saw you last?
I've been on holiday. No, I haven't done anything much. I've been to, because obviously it's not easy to travel in England at the moment. So I've been traveling in England rather than outside of the country. I went to Bournemouth, which has a very lovely beach, and we've been blessed by the weather. I'm sweating a little bit now, as you could probably tell, because it's unusually hot here in England. What about you, Susan?
Yeah, well, I have actually been on holiday as well with all of my family, including 2 people in their 80s, 2 dogs, and a cat that also had a pushchair and a backpack. So yeah, really relaxing. So that's been my
But now we're back. We're live on air, and we're back. We got back just in time for the International AIDS Society Conference, which is a key conference. It's probably the biggest conference in the HIV conference calendar. And as there's some kind of really interesting stories coming out of it already, I think we're going to talk with some of our guests about that. But I believe there's a very special keynote speaker for the closing session. Now, who is it? What's their name? Is it possible? Do you know, Susan?
I'm actually blushing. Yes, I am hugely honoured to be speaking in the closing session about uniting activism, science and policy in an increasingly fragmented world. So if anyone is around and going to the conference, check out my session.
Wow, saving the best for last, eh?
Well, without any, I think we need to bring on because I'm going all blushy, we need to bring on our first guest.
Dr. Tristan Barber. Hi, Tristan. How are you?
Tristan.
I'm really well, thanks. Hi, how are you both?
Oh, we're good.
Yeah,
we're good.
Really good. So I've seen that you have been going to loads of sessions, tweeting like crazy, and including the session at 6:30 in the morning yesterday. But Tristan, what story has really caught your attention at the conference so far?
You know, the 6:30 was easy, Susan. As you know, there's no way I'd miss a session with Angeline and Amoeba presenting. It was absolutely fantastic. A really good start to the conference. I mean, I think it's fair to say in terms of grabbing stories that, the conference is still very early. It only started yesterday and today has been a full day as well. But I think what's come across really strongly for me, and this is so often the case at the IAS meeting, is the really sort of global approach to HIV care that now incorporates so much around COVID. So there's been a lot about how COVID has impacted on people's access to clinical services, access to treatment. But what's really coming through as a strong theme is how we're now starting to look at our very connected world and how we really make sure that access to healthcare is equitable, particularly thinking not only of people from different ethnic backgrounds and different countries, but also, of course, particularly around women and their involvement in clinical trials. That was very much the focus yesterday of that very first session, but also about young people, about transgender communities, and I think also thinking about the environmental impact of healthcare. There's been a lot of powerful stuff around our impact on the environment in providing healthcare and what we can do to try and minimize our impact, because of course climate change is going to impact healthcare, particularly for those in poorer regions, really significantly. So you get this overwhelming feeling of really trying to bring things together in a truly holistic way. I think that's what you really get from this meeting.
There's been a lot of excitement already about the injectables, which there's been two sessions on it. One which was looking at injectables for people who had experienced treatment failure, and another one looking at injectables for people who were treatment naive, for people just starting treatment. What's your thought on injectables? Because there's a lot of excitement I get from the community about this.
That's interesting. You're already ahead of me, actually, Matthew, then in terms of the treatment failure. I haven't seen that data, but injectables, of course, are tremendously exciting. We're looking at now having injectable cabotegravir and rilpivirine already available in the US at a 4-weekly dosing schedule, but we're expecting to have it in the UK, hopefully early in 2022, with a 2-monthly dosing schedule, so injections every 8 weeks. And I think different countries will vary in when they have access to these medications and whether it's the 4 or the 8-week schedule initially. Then, of course, there's been exciting data about lenacapavir, which is a new drug in development by Gilead, which has the potential to be given by a subcutaneous injection, so under the skin rather than into a muscle, and perhaps could be dosed every 6 months, so 2 injections even per year. Of course, what you match that with other treatment to have truly long-acting therapy will be key. But yeah, that drug does seem to work very well over a longer dosing schedule.
So does that mean that we'll need to find other drugs which can have that same life, as it were, that same thing, so that we can actually make the full treatment twice a year? Is that right?
That's exactly right.
Okay, so people shouldn't get too excited yet about having just treatment just twice a year. We're not quite there yet, but
these are still only phase 2 trials. So yeah, we're still quite early in development of that drug. So I wouldn't get too excited about 6-monthly treatment just yet, but certainly 2-monthly injections, if they'd be something that you might like to consider for HIV treatment, I think will be available a lot sooner. And people continue to ask me about that in clinic.
Yeah, I think people get really excited because I think it's much more discreet, and I think also there's that impact that when people take their pills on a daily basis, it just reminds them that they're living with HIV. And if that's an emotional struggle for you, that daily reminder is a burden in and of itself. So I think that's part of the reason why I get a real sense that people get very excited when they hear about injectables.
Mm-hmm. Tristan, I was in a really interesting session with Meg Doherty from WHO about the data around people living with HIV and if we're at increased risk from COVID. What do we know now that we didn't know before?
So this is a big data set, over 15,000 cases of COVID in people with HIV in various different country settings, that did show after admission to hospital, people with HIV had a higher risk of doing poorly, and in fact, a higher risk of death. And my first thought when I saw the summary around this data is that this must be very country dependent. And in fact, I think if you break it down, and this is where it's very difficult still being in a virtual environment, you know, you're used to discussing data with colleagues and with you at these conferences when we're face to face. But from what I can understand so far in looking at the data, the signal was much stronger for people in the WHO Africa region. And I think the signal was not significant in the countries that were from the WHO European region. So again, there's something to understand about these data in a little bit more detail, because it may vary very much according to which country setting you are in. And then also there was some Spanish data which showed that your risk from having severe COVID was worse if your HIV viral load was not suppressed. So again, I think there's a complex interplay of factors here that do increase this risk. I think for most people that are in fairly well-resourced settings, the amount of severity of COVID that's excess if you're HIV positive is probably quite low still, or maybe non-existent in certain country settings. But I think if you're in other country environments, or if your viral load is not suppressed, then it will be that your risk of severe COVID is slightly higher if you're in that situation and HIV positive. So a big data set, very important, helps support previous data sets that we've seen, some of which have shown an increased risk and some of which haven't. But I do think we need to remember that this covers a wide variety of countries and we need to understand the data a little bit more in that context.
I guess one of the things that's really important that kind of we learn from that data is how important it is. Well, one, obviously, that people with HIV have access to HIV medication and are able to continue to take it, which COVID itself has disrupted to a certain extent. But it's also about the vaccination programs and ensuring that people with HIV may need to be prioritized, certainly over some other groups, because we now have that data, and it is from, and often you were talking about how it varies from country to country, but often it's the countries where there might see more of a pattern relating to people living with HIV, where they have very limited access to COVID vaccination at the moment. And so perhaps it's really important to stress this point in terms of prioritization of people living with HIV.
Yeah, I think that's very important. We really recommend now that the vaccine is taken by people who are living with HIV. There's data from most studies to show that it's safe. And I agree, we feel that people with HIV should be prioritized to receive the vaccine where possible. And again, there's data presented at this meeting supporting that. So very, very important. If you have access to the vaccine, please do get it. I fully support personal choice and appreciate some people have concerns, but we have increasing data that it's really, really necessary if you're HIV positive and safe and definitely advised.
Yeah. Tristan, thank you so much for coming on the show. It's always so great to talk with you, and that was really, really helpful to look at all of those reports from IAS. Thank you.
Huge pleasure.
Thank
Many
you.
thanks to both. See you soon. Take care.
Thanks, Tristan. Bye.
So, Susan, what other stories from IAS have grabbed your attention?
Well, there have been so many really compelling stories, but one very worrying report that we've also covered on aidsmap is about an increase in sexual violence and rape affecting young women and girls in Uganda. And it's actually really shocking that found that there's a 24% increase in reported rape and sexual violence, but an actual decrease in women accessing post-exposure prophylaxis to prevent them from getting HIV. So, potentially women are at increased risk of HIV at this time because of the pandemic. And there have been a lot of reports about an increase in gender-based violence, quite widespread globally. So it's also really concerning to hear about that as well.
Yeah, I mean, I saw that report, and it's very distressing. And I think, I mean, it's not just in Uganda. I think it is fairly international because, obviously people do not have the same liberty to be out. Everyone, kind of the emotional situations which people are in. And I've also, it's been happening to LGBT people. Often LGBT people are in home environments where they're not safe, and the increasing levels of violence as a result of this epidemic. It's one of those challenges which the pandemic has thrown up, which perhaps we've not really kind of been able to focus on because we've been so concentrated on first finding the vaccine and then vaccination rollout, and some of the other impacts of it have been perhaps missed. Mm-hmm. I think our next guest, Gina Brown, may also have insight into this. Gina, it's so fabulous to have you on the show. We've known each other for a little while, so I'm really, really pleased to have you here.
Thank you for having me.
It's wonderful to have you on, and absolutely brilliant to hear that Louisiana accent again that my kids had when we lived there. So thank you so much, Gina. But if I could go back to that issue, are you actually seeing an increase in gender-based violence and sexual violence during the pandemic in the USA?
We're hearing a lot about gender-based violence. If you think about it, a person who is quarantined with someone who's beating on them, you can't go anywhere. You have nowhere to go. So a lot of times you're stuck. We're hearing a lot about it, especially down here in the South. And it needs to be addressed.
Yeah. Absolutely, and also another issue. I mean, just in terms of that, we're hearing a lot is an increase in health inequalities. Black women in particular have been disproportionately affected by HIV for decades, and we're now seeing Black women being disproportionately affected by COVID. What can we do to address these health inequities that we're experiencing?
The first thing we can do is start listening to Black women. We know our bodies. We're going to tell you what's going on with us. We need providers to really hear us when we're talking. Another thing we can do is stop acting like Black women are this one group of people. We're not. We're different. So treat us all differently. Treat us the way that when you're seeing a man, you don't treat all men the same. You treat a man with whatever his symptoms are, whatever he's presenting with. That's how we have to do it with women. We have to make sure we're listening to them and we're treating them in a way that's affirming, that's not taking any of their autonomy away, that's not taking anything that, because when I walk into a doctor's office, I own me. But a doctor has a way to make me feel like I don't own me. So we can't do that.
Yeah, absolutely. And what role do you think systemic racism is having in the health inequalities that we're experiencing?
Well, I don't think we have enough time for me to talk about that, but I'll be very short. I think that it plays a huge role. And if you think about it, and I think people sometimes confuse systemic racism with racism, right? So we think that because an institution was built on a racist foundation, that everybody inside of that institution is racist. That's not true. It's just the way things were set up that makes it that way. So we have to change. We have to really change the way our systems are created and how they operate. I think about this often because as a woman, a Black woman living with HIV in the South, I think of the things that I don't have, the lack of, and why I don't have those things. It was a long time before I had health insurance. For a long time, I relied on the AIDS Drug Assistance Program, the Ryan White Care Program here in the States to get my care, even with a job. Because insurance companies wouldn't insure you at first, so it was that whole thing. And I think a lot of it is because of systemic racism. I'm sorry.
Yeah, we've seen data. I think the data I was looking at was here in the UK, and it was just really staggering how Black women were less likely to have their mental health needs met or addressed, that they were less likely to be believed if they were experiencing pain. And so, and then, I mean, I think there's been a slight bit of the silver lining of COVID has been that we are having a much more nuanced, much more detailed conversation about these health inequalities, which have been through generations. And it's like finally people have noticed, and we're like kind of going, look, because we could point to the mortality rates, which were starkly different. How has the COVID-19 pandemic impacted on HIV care in the south of the USA?
Well, the city that I'm in, New Orleans, I can tell you about the clinic I attend. Everybody who walks into that clinic is offered a COVID vaccine, everybody. So they are really, really proactive. They're one of the places that when COVID first started, they set up a testing in their garage at the clinic. So it was outside. Anybody could go and get tested. It was really easy. It was free. So they were encouraging people, especially people living with HIV, to come and find out if we were also living with COVID. So we would go in, get tested if you didn't have it. This was even before the vaccine. They asked you, if a vaccine becomes available, will you take it? So they were asking the question long before we had a vaccine.
And what proportion of people in the US are vaccinated now?
In Louisiana, where I live, less than 50%.
Okay.
In the parish that I live in, less than 44%. So people are not getting vaccinated at the rates that I think we should.
And are the disparities falling along race? Is it on race grounds, or what? Where are we seeing the biggest inequalities?
We're seeing the disparities around race, and it's not even Black people. You would think it would be Black and Latinx people, and it's not. It's a lot of white people in the rural areas who are saying that they're not going to get vaccinated. So having a conversation and trying to get people to not get their news from social media, to go to a real, someplace that's telling the truth. You're going to get some truth, that kind of thing. So really having conversations with people, but also listening to people and finding out what are they hesitant about.
I think that's such a vital point to make, is that it's very easy. I think I work in public health. I've been working in public health for 20 years. And, I get people kind of like saying, oh, can you condemn this behavior or that behavior or whatever? And it's like, actually, you need to listen. Start off by listening. What is the problem? What is it that you're not understanding? What is it that you're misled about? And if you listen respectfully and take people's concerns respectfully and deal with them with respect, then usually you can allay them. And if you can't allay their concerns because maybe we don't have enough data, then that tells you that we need to get more data, we need to get better data, we need to make sure that the data we've got applies to people living with HIV, that it applies to all ethnic groups, it applies, some people's concerns are genuine. And that doesn't mean to say that they're right, but they have a right to be concerned. And they also have the right to be educated, informed, equipped, and empowered. And that is how you help people to make the right health decisions for themselves. Sorry, went off on one. You know what I'm like.
Yeah. Thank you so much, Gina, for coming on the show. It's been wonderful.
Thank you for having me. Okay, bye.
Thanks. Bye.
I know. Sorry, I did just go off on one, but it's just like all of this stuff that I've been seeing today. Because today in the UK is Freedom Day, so all of the restrictions which we had in place are now no longer happening, and people are responding to that in very different ways. And some of them, I'm thinking, well, that isn't how I would respond, because I don't actually feel safe enough whilst cases are going up, and I am double vaccinated. But that's still 93% protection against hospitalization. Hospitalization sounds pretty bad to me. That's something I still want to avoid. So I'm being very cautious. I'm not going to be clubbing anytime soon. Also, I'm really old, so I probably wouldn't be in a way.
That did not cross my mind at all.
I felt I had to leap in there before you said it. Let's get our other guest on before you say anything mean. Arda Karapinar, how are you?
Hello, Matthew. Hello, Susan. You look good.
You
look awesome again.
And you are looking wonderful, as always.
Thank you so much. Thank you so much, and thank you for having me.
I would be indiscreet if I said something like Susan always goes on about how ridiculously handsome you are. So I'm not going to say that.
Moving swiftly on. Arda, what would you say in terms of, like, I understand that Turkey is quite a traditional country. How endemic is HIV related stigma in Turkey, and what impact is that having?
Actually, not only traditional, also we easily can say it's a conservative country, and when religion is really effective in the society, it's working on this kind of stuff always being difficult. But I've been many different places of the world, and I think this is not really difficult. Of course, this tendencies are more a bit different, but it's always possible to find creative ways, and it's always possible to find good solutions for the situation if you took them separately. But as a short answer for your question, I can say it's not really easy, but it's not that difficult, and it's also sometimes gives great opportunity that you always should reconsider about the situation and find a solution.
So Arda, I first met you, I think, in 2017. It was when another International AIDS Society conference was on, and we
Paris,
met.
I suppose.
Oh, do we meet in Paris? Okay, yeah. I was thinking of Amsterdam, because Amsterdam was the conference where there was the pre-conference about U equals U.
Yeah.
And
okay, so Paris or Amsterdam, it doesn't matter.
And I wanted to talk about that because you have been, like, really powerful advocate for U equals U in Turkey and internationally. And this week we are celebrating the 5th anniversary of that powerful message. So what has U equals U? Undetectable means untransmittable. It's the knowledge that when we are on HIV treatment, we can't pass the virus on to our sexual partners. But what has that meant to you personally?
Yeah, thank you for this question, because U equals U means a lot to me, and not personally, but also organization. I mean, 5 years ago, I decided to go for new NGO in Turkey, Red in Istanbul. By the way, now aidsmap is one of the role model for me when we decided to create this new organization, and HIV information charity. I can say that. I proudly can say that. What I can say about U equals U, I mean, not only personal, but I want to say something about globally and for all of us. U equals U made us real family, actually. I mean, before U equals U campaign, I remember that there were lots of arguing, you did this, you did that, you said that, or all this bullshit. And some of them are still around, actually. But when we are talking about U equals U, all of us being good friend and good family, suddenly, that's why U equals U is so important. And of course, there are some personal point from personal importance for me, because I think Red Ribbon Istanbul is one of the first organizations from Europe to sign the campaign, because I remember the moment I was working on in front of computer in night, and I just saw the email from Bruce, and I replaced him. And then, he said, I really don't know where is Turkey on the map, but your email was really interesting, and I'm really happy to have you. So, and then it was a really interesting journey for me and for us in Turkey, because there were lots of barriers, lots of what's the word? I mean, lots of doctors said that no, this is not good. You shouldn't do it. You should erase it. You shouldn't publish it, etc., etc. But at the end of the day, after 5 years, we did a lot. But the other thing, what I want to say, just imagine that U equals U is only 5 years old. I mean, 5 years is really long, but just 5 years old. So just imagine year 10, year 15, whatever, even year 7, whatever. But we still can do a lot, and that's why I'm so passionate about U equals U.
Yeah, I mean, I really hope that by the time we get to the 10th anniversary, everyone will know. What do you think is the most? What's the best way of communicating the U equals U message? What do you think is the best way of communicating the U equals U message?
Firstly, listen, people. I mean, we're so insisting to give our message, because we have some templates in our minds. This is the right information and this is the right way, and you should understand. But some people are understanding and taking it in different ways. So our first priority is listen people separately. It doesn't matter it's healthcare provider, people living with HIV, or people from street. It doesn't matter. Firstly, we should listen why they are insisting to take this message. So then we can understand, and we can create unique way, unique strategy to explain them. And there is no single case that nobody understands, nobody gets the message.
Yeah, it is interesting, isn't it? Because actually, often it's people living with HIV who find it a struggle to accept U equals U, because it overturns all of those years where they have felt diseased, where they have felt like they are a vector for transmission, where they felt that they're a danger to their sexual partners. And actually coming to terms with the fact that you're not a danger to your sexual partners, for some people, can be quite a challenge.
It's really difficult to accept, because all the message, what they receive, you know, you're always problem, you're dangerous, etc., etc. And one day, one statement and someone says that no, you're not dangerous, and that's simple. It's really difficult to understand, difficult to accept, because it is so simple. I think this is the problem, and that's why we are thinking that, okay, why people are not taking this message, because it's so simple and it's really against the old pattern. So that's why we really should keep knocking door, day by every day.
Every day.
Wonderful.
We keep knocking. Thank you so much, Arda.
Thank you so much for coming.
Thank you for having me.
Arda. I can't believe we've run out of time, Matthew.
It always goes by so quickly, and you know, here I am back at work after a holiday. Lovely to be with you again, Susan.
And you. So thank you all for watching us today. Next week we will be coming back with an aidsmap live IAS special. So we will be having Dr. Laura Waters, who is one of the plenary speakers, and also Meg Doherty, head of HIV at WHO. So do check that out.
I definitely will, because I won't be on it. Thank you so much to all of our guests, Tristan, Gina, and Arda, our sponsors, Lloyd's Pharmacy and Theratech, and everyone at Disruptive Media. And see you next week for aidsmap Live.
Thanks, everyone. Bye.